Good morning. I'm Carlin Bowman, and I'm a senior fellow here at AEI, and it's a pleasure to welcome all of you to this morning's discussion of the opioid crisis and what Congress can do about it. Today's discussion is one of a series of events that will be taking place at AEI on the crisis and on addiction more broadly in the coming months, and I urge you to stay tuned for AEI's announcements. In a blog post last week, Arthur Brooks, AEI's president, wrote that AEI scholars have been searching for new ways to promote work and family formation and policy design, to reintegrate incarcerated individuals into society, and to expand opportunities for career and technical education, and finally to tackle the opioid crisis. What these events and other ongoing work of our scholars at AEI have in common is the efforts of our scholars to create better policies on behalf of human welfare and human dignity, to turn, in the case of opiate addiction, lives of despair and desperation into lives of dignity and worth. We're especially fortunate to have two individuals who are in their own important ways on the front lines of this effort. Congressman Greg Walden represents Oregon's 2nd District in Congress. He has had long experience in government, having served in the House of Representatives in Oregon before coming to Washington. He is chair of the Energy and Commerce Committee, where he has held hearings on different aspects of this epidemic. He wrote recently that some preliminary data from the states indicate that the number of overdoses in the first 6 months this year have already surpassed last year's totals. Congressman Walden has called for better and more reliable data on the scope of the problem, and he has been relentless in trying to get answers from the DEA about its monitoring of pill distribution. In addition, he has called for an increase in overdose prevention efforts and better strategies for combating the crisis in local communities, including in his own district in Oregon, where the ravages of the epidemic have been especially severe. I would also like to shine a spotlight on the work of my friend and colleague, Sally Sattel. Dr. Sattel is a resident scholar at AEI and a staff psychiatrist at a drug clinic in Washington, where she worked for many years. One of her first publications for AEI was a booklet called Drug Treatment: The Case for Coercion, in which she argued for the effectiveness of mandated treatment for drug abusers. In it, she discussed the potential of drug courts, an idea that is gaining currency thanks to her efforts and the efforts of others in this room. She is a firm believer in incentives, whether it is for the donation of organs or treatment for drug addicts. The power of incentives, she believes, can override the lure of drugs. If you haven't read it already, I recommend her article in the summer edition of National Affairs, available on AEI's website, in which she traces the roots of the current crisis, explains why it is different from previous drug epidemics, and then discusses options we have for dealing with it. Dr. Sattel is an original thinker, a fearless advocate, and a wonderful colleague. Dr. Sattel will lead a discussion with Congressman Walden, and then she will hold a discussion with experts. I urge all of you to follow AEI's activities this week and the Institute's work in the weeks and months ahead on the dignity deficit. Sally.
Thank you, Carla. A lovely introduction. So it's an honor to be with you, Mr. Chairman.
Good to be with you.
And we're going to talk for 20 minutes about the opioid crisis and what Congress can do and what your committee is doing specifically. And that will be followed by a discussion with 3 other experts. So there's supposed to be a slide that comes on now. And okay, great. And I'm not even going to discuss it except to say it's everything you, in a sense, it's the picture both kind of literally and figuratively that hangs in the backdrop of this problem, which is this particular picture depicts opioid deaths and how they're increasing, and how fentanyl and heroin are now driving the deaths as opposed to painkillers. So let me start by asking you about as chairman of the House Energy and Commerce Committee, what are the priorities with respect to the crisis?
Well, there's several-fold, and first of all, thank you for your good work on this, and thanks to AEI for focusing on this incredible, deadly epidemic in our nation. So a couple of things. We're coming up on the anniversary of 21st Century Cures, the bipartisan, bicameral legislation that was signed into law last year, that part of which deals with this problem. And about the same time, we passed the CARA Act, which had multiple bills wrapped up in it, 11 of them from Energy and Commerce Committee members. We're going to be doing reviews of how that legislation worked, what's not working, where do we need to go going forward. So that's one piece. What have we done? What needs to happen going forward? That's where $1 billion was put out and is now flowing into our communities. So there's a lot of work back to the ground. I've done 2 roundtables in my district to say, okay, Oregon, you got $6.5 million. How's that working? What are you doing with it? What are the next steps? And then we're also doing pretty thorough investigation work through our Oversight and Investigation Subcommittee. Began in January and continues to ramp up to really get at the heart of the problem, the pill dumping, the patient brokering, enormous volumes of pills going into really small rural towns in some cases. Kermit, West Virginia, population 392, had millions of pills dropped into that community. It makes no sense. So we're demanding answers from the DEA, we're demanding answers from the distributors, so that's a piece of it. And then we held what we called Member Day, where some 50 members of Congress had the opportunity to come before the Energy and Commerce Committee, put forth ideas that they have developed out of their communities and their districts of further legislative effort that needs to be undertaken. So it's a multifaceted approach, investigative, review, future look at legislation to deal with this issue.
Great. So about 3 weeks ago, the President's Commission released its report with, I'm told, 65 recommendations. You add the 9 interim recommendations and I think 56 they had in that most in their final report. That's a lot of recommendations. I've looked through them, and I'm sure you have, and frankly, they seem all very good.
Yep.
But something was missing, which was money, of course.
Right.
And are you optimistic that we'll be able to get it?
I think that's the next phase. First of all, let's look at those recommendations. Let's evaluate them. Let's see what you need legislation to implement, what can be done by executive order. I was with the president in the East Room when he initiated his executive order in this matter, declared it an emergency. There's some really smart things they've done there. District like mine that would stretch from the Atlantic to Ohio, these very rural areas, accessing more telemedicine assistance. It may not sound like a big deal. It's a big deal. I think that's really important. There are other things contained in there, allowing some of the Ryan White funds to be used. There's a comorbidity between HIV/AIDS patients and opioid addiction, and so that opens the door to some funding, getting the right staff in the right places. So I think there are some good ideas there going forward. I know this wasn't necessarily one of them, but the DEA Take Back Day that occurred October 28th, tons of drugs were recovered, pharmaceutical drugs. In my own state of Oregon, 5 tons of pills were turned in. And so there's some common sense things we can do. I've said if I go to, I'll say Staples, I'm probably not supposed to name any particular company, but if I take my ink cartridge in to get a new one, I know I can take the old ones in, drop them off, recycle them. And why don't we have a system like that as part of our culture for excess pain medicines, all medicines, a recovery piece. So, and then we'll get to the money piece. We know we have to do money. I don't know what that number is yet. We want to make sure the $1 billion we put out there is having an effect, but it's something that's
It does seem like it should be more than $500 million a year, in my view.
Right, and I've seen, remember that's not the only place we're spending money on this, it's just the direct. My colleague David McKinley from West Virginia points out that he can't even find out in West Virginia where the money's going that we have put out. And you've got these tiny little rural towns who are least able to cope that don't get any help.
Yeah.
So.
Speaking of those, and that's where telemedicine could help, but speaking of those tiny little towns, there was one recommendation. It was in the interim, but not in the final report, but since I'm told the interim counts. And it was like expanding license reciprocity for doctors. People like me, and to be honest, I've been thinking about doing such a thing, which is, going for 6 months or a year to some place that has no psychiatrist at all. And I can tell you, without that kind of relief, it will take 6 months to a year, unless the
Right.
officials step in to get licensed there.
This is a big issue, and something as we evolve in the internet age, I'm not sure licensure is keeping up. And I respect states' rights in this matter and all, but we find it in trying to get access to exactly those types of services within our VA system. We know it's a problem when there's a catastrophe, a major emergency, a flood, a hurricane. We try and wrestle with how do we do that. This is a national emergency. We should be figuring out how to make sure the type of professional care you're licensed to give can be given across arbitrary state lines, especially when you're trying to help people in addiction that need access to Suboxone.
Yeah.
You know, we changed in CARA that you could oversee more than just, I think the limit was 25 patients up to that point.
Well, it's 30 the first year, 100 the second year, and then you can register for 275.
But it was frozen at 25,
Oh,
I believe, prior to that change in
Wasn't
the
aware of
law.
that.
And so there was a limitation in any case. I had a constituent who had to drive 5.5 hours each way to find a physician that could help her get off of the addiction she was on, because there was nobody locally that could take her. She's now very much involved in the whole advocacy program and treatment in her community.
But we have this real paradox. On the one hand, yes, doctors were way too just generous with prescribing pills for both acute and I'd say chronic illnesses. And but there are patients now who maybe with chronic pain, and maybe when their chronic condition developed, they could have been treated with non-opioid
Alternative pain
solutions
management, yeah.
or alternative alternative procedures with fewer opioids. The point is, after 10 to 12 to God knows how many years, they've been stable on opioids. And in fact, I got a letter a few months ago from a woman who was a physician herself and has interstitial cystitis, which is one of those horrible conditions where it's an inflammation of the bladder and you feel like it's on fire. I mean, it's just terrible. And of course, it's every day. It's excruciating. And she said not to be melodramatic because her doctor was just about to cut her off. She was even on some methadone, low dose, about 40 milligrams. And that doctor was about to cut her off because there's such fear now among doctors that the DEA may come after them for overprescribing. And she said, I don't mean to be melodramatic, but I think I might kill myself if I can't find another doctor. And luckily, she found someone in Stanford. She was on the West Coast where there tend to be more sophistication around medical centers. But it's a terrible problem. Is that something Congress can address?
We have to be very careful in this space, and I think in the course of our hearings and discussions, we've had try and have a marker that says, remember, you've got 27 million Americans with chronic pain.
Yeah.
These are cancer patients. These are people with diseases
Or
like
chronic,
you.
right.
Chronic.
Musculoskeletal problems.
And so we can't do what Congress traditionally does, which is overreact and get it wrong, because there are people that will suffer dramatically. But we also know that there's been enormous overprescribing, enormous over distributing. We found this report of a community, again in West Virginia, not Kermit, I think it was Oceana or something. Anyway, they had people lined up on the streets to get their opioid prescriptions filled at a pain center, and there was a pharmacy nearby. So much so that they actually put up hot dog stand.
I was waiting so long.
And another place had doctor in flashing. This is going on in America. And so, yes, on the one hand, you have people with real need, and we need to make sure they're cared for. But on the other hand, you have pill mills and pill dumping, and we have to get at that, or that chart's going to continue to go like this. Why is marijuana a Schedule I drug, and I believe fentanyl and 20 some other synthetics are not? John Katko has a bill that would fix that, so that law enforcement could go after some of this quicker.
Yeah, and it's tough because the analogs in China where they make these change so rapidly that they're not listed, and so.
That's exactly the point he's trying to get at. And then how do you keep it out of the market, the excess pills? Congressman Wahlberg had an idea at our member day about people in hospice, when they pass away, the medical professionals should be able to confiscate the drugs that are left behind.
Did you hear these stories where they've not even, in some towns, they're not even putting death announcements in the paper when someone died in hospice or home hospice, because that means there is probably a cache of high-dose opioids at their house. Anyway,
I have had 2 instances in the last 12 months of people who had injuries who did not want to take the opioid that was being prescribed for them, said, no, I don't want that, I just want Tylenol, or I want something else, I don't want that. And in 2 separate cases, they've said, somebody associated with the healthcare delivery system, I'll be broad about this, said, well, you should take them because you can always sell them if you don't use them.
What? And that's
I am not making that
$1 a
up.
milligram. That adds up.
That adds up. That culture is out there, even within the healthcare delivery system.
That's shocking.
It shocked me, and these are both people I know well, both have some knowledge of the industries, and they said, I actually had this person tell me this.
Wow.
So,
That's
I mean,
usually
this is
something
so
people come up with on
ingrained.
their own, you know.
Yeah, this is so ingrained culturally. And we know from studies that upwards of 94% of people responded to one study who were trying to fight their addiction on opioids and ended up on heroin, said they started on the opioids. Yeah, I mean, you go to the cheaper, more available.
Yes, that's true. That's
when
why
the
more people
prescription
are
runs
starting
out.
on heroin now, actually.
And your charts indicate that.
Oh, yeah. It's true. More and more. Right. The Cicero study, I think, was published in 2014, which means the data are probably from 2012, where 1 in 4, 1 in 5 started on, prescription pills, and now it's more like 1 in 3 because people are, as you say, the cheaper and most available substance. So now we're talking about shopping thing. Let's turn. We don't have too much more time, but let's turn to patient brokering, and maybe you can say a few
So
words
this is a
about
new
that.
area of investigative opportunity. You have reports of some pain centers that are now, or others that are now paying people $500 to $5,000 to bring in a patient.
Yeah.
Offering them free cigarettes, manicures, all kinds of inducements to come into my pain center. We're investigating, so I'll be somewhat judicious here. There are reports, then we're trying to figure out what is it that motivates that behavior and that payment for these recruiters, if you will. And so we're going back up that value chain to look at, that's a lot of money. And so what is they're getting compensated for? There are public reports out there about, a whole new lab testing regime that's going on and whether or not that's necessary.
And charging $1,000 for one urine test, right?
So if you can charge $1,000 for a urine test, you can pay $500 to get the patient in the front door.
Gosh. And the places, though, they send them to for treatment
Maybe
are
self-referral
are
too.
very low quality, and often actually are, well, I have to admit I read this, but there are many reports, and I have no reason to not believe that they send some of these patients to, frankly, work camps without any kind of real counseling, or maybe an AA meeting here and there. So that's pretty drastic.
So we're looking at patient brokering. We're looking at pill dumping. We're looking, again, we need the DEA to be our partner. We've had struggles with the DEA to get the information we've sought.
Yeah, I'm just going to ask you about one more thing, and then maybe you can take about 5 to 7 minutes of questions.
Sure.
Okay. So there's a bill that was passed a few years ago called the Excellence in Mental Health Act, and one of its main feature was that it was basically focused on something called certified community behavioral health centers, and their virtue is that they could offer a highly integrated system of care. There was enough money for, I think, just 8 states because it was based on Medicaid waiver money, I believe, or expansion money, excuse me, and a Section 1115 waiver.
Okay.
And this year, some members of your committee, Representative Lance and Matsui,
Matsui, yeah.
as you know this, of course, have introduced the Excellence in Mental Health and Addiction Treatment Expansion Act. What do you think its chances are? This would, in fact, I think, extend the demonstration project in your state for another year and add 11 more states for this demonstration. Because
I think
we
they're
know
really
that,
talented committee
integrated
members.
care is
I think they're really talented committee members who
Yeah.
recognize that the chairman's from Oregon, and extending the program in Oregon would probably be a good inducement for the rest of the bill. Look, it's really important work, and there is a demo program going on in Oregon to look at the efficacy. Is this working? We do a lot of wraparound coordinated care.
Oh, that's huge.
And we're finding good results as a result of that. You mentioned drug courts earlier, or somebody did. We've got drug courts in Oregon. They show great promise and great outcomes. The legislation specifically, I'm not going to forecast what we're going to do, but I'm a fan of this wraparound coordinated approach to healthcare that has both the medical side and the other counseling side. You need both. Oregon took it a step further in state law this year that I think is a step backwards. They took all the Schedule I drug penalties down to a misdemeanor for any Schedule I. The drug court judge, who's a friend of mine, at a round table I had, was really disturbed by that, because she said, now I don't have, I don't have the stick.
Yeah.
I just have a carrot. And when I had the stick, people would then go, oh, well, I don't want that felony on my record, so yeah, I'll come into this diversion, I'll come into the drug court process. And they were in there long enough then to get the treatment, get the counseling, and graduate in a way that puts them on a path toward success. She's very concerned that with that gone, the inducement's gone. If it's just a misdemeanor and a traffic ticket.
You said the key word, stay long enough. And most people, I'm speaking as a clinician, do not stay long enough. And so these kinds of wraparound and kind of leverage from drug courts, huge.
Here's the other thing that I hope those of you who are certified smart in these areas will also look at is the transitional housing post-treatment. I've seen it in the veterans community, I've seen it in the other non-veteran community. These are, in some cases, people who have been living on the streets, get into the addiction treatment program, they graduate, they're clean, they're sober, and what do? We say, hey, thanks for coming by, there's the door, have a nice life, and they have no income, they have no, and they go back on the street and they re-abuse. And so there are some really good models, the Oxford houses and others, that bring you in, get you on your feet. It's affordable, you have a room, you're part of a governance structure. By the way, they found in Oxford House, the governance structure actually adds to the success rate. So it's not just a bed in a place. You actually are part of an organization. There's internal accountability, responsibility, and the results are enormous, and it's a very cost-effective private-public nonprofit partnership that goes on. But if we go through all of the success and then drop people at the curb, they go under the overpass or whatever, and in some cases, and we lose them again.
Sure. And they may die now because their tolerance is so much lower.
A really important point that I did not realize is that whole tolerance change, and that they did tell me people go back out and go back to what they were taking before, not realizing their body's adjusted. And
so maybe two questions?
Sure.
Okay. Sir?
You got a microphone coming right behind you there, sir.
Oh,
Thank you.
Oh, please introduce yourself.
Yeah.
Yeah. Joel Cooper-Smith, I'm from Georgetown University. Two things that I think abetted this epidemic were pain management experts 20 years ago advising much more widespread use of opioids.
Right.
And I think also outpatient surgery, where instead of having the patient in the hospital taking intramuscular injections, you give them a bunch of pills, and they may often excess. Do you think that the medical societies now are doing enough in terms of articles, guidelines? are they being restrictive enough? I mean, I go to the dentist, for example. I went to the dentist 3 or 4 months ago. I was given opioids, Percodan. I needed 2 Advils to control my pain, one dose of 2 Advils, and yet this is routine, and you can't, you try to tell them not to prescribe. I asked not to prescribe it, and then I was given a prescription for it on my way out. And I think the medical societies and the professions have a lot to do here.
I would agree with that, and I think they are recognizing that and addressing that, and the legislation we passed basically called for professional societies and our government agencies to work together on best practices and new treatment regimes for pain management. But we still have a long ways to go on that. But they have to be a partner in it. I mean, if you think about it, it does start with somebody writing a prescription. And so that's been part of our initial focus. And when I've talked to physicians, more than dentists, but physicians, they say, I got like 1 day in med school on what I do with this. I'm probably exaggerating there, imagine, but they don't feel like they got the full download they wish they had about pain management and prescribing opioids. And you're seeing, I think, a renaissance moment here. Now, I'm also talking to oncologists who are concerned that they're not getting their prescriptions filled, that we're tightening down so much. I'm being told by some of them, they're running into a real second guessing now about whether this patient should have these pain meds. And so this is a science, it's an art. Medicine is an art. And we have to be careful in public policy. We don't just say, well, I don't care who you are or what you have, you only get 3 pills a day. That's not our role. Our role is to rely on the scientists and all in this area to say, what's best public policy here? Clearly, we opened the gate too wide and too many prescriptions are out there. Clearly, we need better take-back regimes. One of the things we did in the legislation we passed last year is say you don't have to fully fill the prescription either. You can do a partial fill. Prior to that, the law said something different. And Scott Gottlieb at FDA is doing some remarkable work there to try and look at it from the FDA perspective. But I think you've hit upon it. That gets the pills out into the cabinet that sit there until somebody steals them or sells them.
Yep.
That's a piece of this.
I was going to ask that gentleman over there.
Yes, Bernardo Rico, the World Bank. This is more of a personal question. It doesn't represent my institution. I couldn't agree more that this latest drug crisis in the United States started as a prescription opiate problem. But if you just look at it in terms of overdose deaths, so maybe looking at the numbers that you have up there, so in 2010, I think it was 91% of the overdose deaths were related to non-illicit drugs, so legal drugs. Okay, methadone and heroin. I'm sorry, and the pills. And if you look at this year or the last year that you're projecting for, you're talking about 71% are actually illicit drugs, and I put fentanyl on that because it's still illicit. It's still legal to acquire fentanyl. Why are we continuing to have a discussion? Only it seems like I know that many people, the drug problem is a multifaceted problem, requires a multidisciplinary approach to solve it. But it seems like there's almost an obsession with just continue to focus on the prescription opiate problem when we have an illegal drug problem that's killing Americans today. 71% of those deaths in 2016 will come from illegal drugs.
Illegal drugs or legal drugs?
Illegal
drugs. So in using 2015 data, drug overdose leading cause of accidental death in the U.S., 52,404 lethal drug overdoses in 2015. 20,101 of those were related to prescription painkillers. 12,990 were related to heroin. So 33,000 out of 52,000 were either painkillers or heroin, but all opioids. So that's part of why we're fixated on this. And fentanyl coming in, as you see that spike, and its synthetics, they tell me that a piece of fentanyl the size of a grain of salt, if touched, will kill you. And so it is very deadly. And now the drug dealers, I'm told, are cutting fentanyl into heroin. I assume that's to add to its addictive nature. I don't know.
It's a marketing thing. You just don't need so much, so it's cheaper.
And you can always trust your local heroin dealer to get the right percentage. It's all safe. That's why you see these pockets of death, because it's so deadly, so potent. But you're right, we still have to deal with both, and so that's the cartels, that's everything else. I've met with the Chinese ambassador. We're trying to do a better job. A lot of this coming in from China or up through the southern border, Mexico. Some of it's coming in through the Postal Service. Some of it's online. The administration's taken down one of the biggest online sites recently. So we're trying to, but the demand is so high in the U.S., and the price, the money here is so big. You've got all kinds of operators, including distributors and manufacturers, as we know from various public stories, played a role in this too. By the way, our committee's looking from one end to the other.
It's 10:33. Do you want to take one more?
I can take one more, yeah.
Yes, ma'am.
I'm Marcia Simon.
Why don't we wait till the microphone comes here, Marcia?
Sorry.
Thank you.
Thank you for coming.
Delighted to be here.
I'm Marcia Simon, and I'm a health policy consultant and a former Hill staffer. And I wanted to ask you about efforts by the committee to do something about the increase in costs of the overdose reversal drugs and also the drugs to treat opioid addiction. And I'd like to suggest that the committee might like to look at making first responders eligible for the 340B program.
It's an interesting concept. Couple of things. One, as you know, we reauthorized Food and Drug Administration programs, PDUFA, MDUFA, GDUFA. I learned I have all these UFAs under my, we have a UFA coming up, that's the animal one. But we did all that, and we looked at, within the context of that legislation, some bipartisan work that Kurt Schrader from Oregon and Gus Bilirakis from Florida had on the generic side, that if there isn't a competitor on a device or a drug, you could go to the top of the approval process to try and get competition into that market. Believe me, when it comes to some of these enormous price spikes that have occurred when somebody, generally a Wall Street financier, buys a patent and then there's no competitor and they drive it up, think EpiPen, think a couple of these things. We're looking at how does that happen in that value chain, and so we get it right. My own wife used to carry a EpiPen around, and when they were $75, it was one thing. When they were $600, her doc said, well, you can probably be okay with your deal on Benadryl, so just make sure you've got those. Not everybody's in that category. We know in the naloxone and the little device to insert it in your body, that's what spikes it. It's not the price of the underlying medication. And so these are things we are looking at, and will continue to. It's interesting, in Oregon, at one of the roundtables, under the Oregon Health Plan, they actually, I think this is correct, prescribe naloxone when opioids are prescribed. And the physician who was telling me about this said it has a remarkable sobering effect on the recipient of the opioids. When you say, by the way, these are so potent, we're giving you the antidote here in case you overdose. And they're like, what? What are you talking about? And so that's a pretty good educational campaign in and of itself. First responders, of course, have them, but there's a range of price. They told me it was about $50, and they are all saving lives daily. Of course, into your pharmacological world, apparently when you get that, you're really not happy because you go to withdrawal right away. And then they tell me there are people that after a period of a few hours can go back into OD and have to have it again. So all these are cost drivers. There are issues. I hadn't thought about the 340B process. We're looking at 340B overall as part of our work and how those funds are being used. So.
Well, thank you so much. It was a really great meeting.
Delight to be with you all. Thank you, and thanks for the great work AEI does.
Thank you.
Appreciate it.
my esteemed panelists, or more like discussants, this isn't a panel. Excuse me, sorry. Okay. So we'll start with General McCaffrey, General Barry McCaffrey. I'm sure you all know him, but he served in the U.S. Army for 32 years. When he retired in 1996, he was the most decorated general serving in the United States Army. And that prepared him for the office of ONDCP, which is the drug czar's province, where he directed the office from 1996 to 2001 under President Clinton. Now General McCaffrey is president of his own consulting firm based in Alexandria. His bio, as you can imagine, and his awards and recognitions are extensive.
I'd encourage you to read more of it, shall
yeah. Right, but we'd be here all day if I did. So, moving on to Dr. Eleanor McCants-Katz, who is the first assistant. This is a new position created by the 21st Century Cures Act. First assistant secretary for mental health and substance abuse. She received her MD from the University of Connecticut and PhD from Yale. Most recently, she served as chief medical officer for the Rhode Island Department of Behavioral Health Care, Developmental Disabilities in Hospitals. And prior to that, she was medical director for the California Department of Alcohol and Drug Programs. She's also the director. Let's see, are you still the director of SAMHSA? You're now running SAMHSA and more. So, okay, but the most important thing is that Ellie has been my friend for about 30 years. We met at Yale, and we've been friends and colleagues since then. And I'm so proud that she has this new position. And Mr. Carson Fox is the Chief Executive Officer of the National Association of Drug Court Professionals since 2015. But in 1996, you helped establish the first drug court in South Carolina, where you're from, right? And served as its prosecutor and administrator for 5 years. During your tenure at NADCP, I see you developed curricula policy for a lot of drug courts, and I'm just listing a few of them. The juvenile drug courts, tribal healing to wellness courts, veterans treatment courts, and I'm going to stop there, but the list goes on. It's very impressive. And the same applies to both of Dr. McCants and Mr. Fox in terms of their achievements. I've abbreviated them here. So we'll go till about 11:15, so we can get in 15 minutes of questions from the audience. But I'll start here by just saying, Chairman Walden said a number of things that kind of comport with my own bias, which is that we need to be putting, I think, more effort on the demand side of the ledger. And I still think the supply and demand reduction models work pretty well, and then there's a harm reduction element as well, but supply and demand, reducing demand meaning treating people so that they no longer want to use these drugs. And I think we're kind of on the right path, although you did paint some scary pictures. But I think, we are on the right path in terms of pills. They haven't been reduced enough, but the deaths from overdose are going down. Substance abuse disorders with prescribed opioids are going down. Doctors are becoming more cautious, notwithstanding your experience, because that does still happen, where doctors still give you too much, but more of them are being cautious, and there's much more sensitivity to it. And as we said, sometimes too much sensitivity to it, where people are denied the pills they use. But nevertheless, and we're working on the Postal Service and the DEA, all those things he said. But, the treatment infrastructure isn't great. There's a lot of medications we can use that are not to help people, anti-addiction meds that are not being used. Patients, as we mentioned, drop out too often, so how can we engage them and hold them? And clinicians have to be, I think, engaged too, because treating this population is difficult. And at some point in our discussion, I'm going to turn to Dr. McCants-Katz, because when she was at Rhode Island, they developed a very interesting program for starting people on buprenorphine. So with that, I'm going to throw out the first question, and I'm not going to ask as many questions as I did before, but just to get this started. General McCaffrey, how do the challenges that are present now compare to the ones that you faced when you were drug czar?
Well, that's a good question. I was one of the opening speakers at the RX Opioid Addiction Conference last year in Atlanta. And did the same thing in the state of Washington a few months ago. I think one of the challenges that we face in this issue in general is not to focus on the drug du jour. Right now, this devastating loss, obviously, of opioids, a lot of it triggered by fentanyl, is simply incredible. Having said that, methamphetamines, crack cocaine, the most dangerous drug in America, bar none, cigarettes, over, better part of 400,000 a year dead, alcohol, 88,000 dead a year. So one of my personal viewpoints has been the demand reduction, which focuses on adolescents with science-based credible programs and which draws in pediatricians and coaches and moms and homeroom teachers, is at the heart of soul of dealing with the opioid problem, never mind polydrug abuse in general. I think the second thing that many of us believe is we've really lost our focus in terms of setting a tone in America that says, as a general statement, we're not trying to arrest our way out of the problem, but we are willing to step forward and say that a drug-dazed lifestyle that has impact on your job performance, your social relationships, your criminal record, and your health is devastating. And so are we willing to speak up? We had this incredible public communication strategy, the Clinton administration, and it slowly died out over the years, where we tried to speak credibly to different audiences and why drugs are harmful. It's gone. And actually, to my astonishment, the Obama administration was terrible on it. Sort of a tolerance of, come on, grow up, what's the big deal, a little pot, do a little blow, you'll get through it. So I think our communications health strategy has been devastatingly lacking. One final, and it should be a minor point, but I've spent a good part of my life in and out of hospitals. And, I think Dr. Sattel and I share a common concern. In the rush to deal with opioid addiction, let's not forget about pain management. A good doc will tell you, come on, pain's a background factor. I'm trying to save your life. But to a lot of us who've been in and out of hospitals, it's the factor. And so I've been skeptical about the sort of the Rush Limbaugh approach. The docs made me do it. And so we're going to intervene in what should be scientific-based medical decisions on the prescription of painkillers. And by the way, just a quick thought on drug courts. We've got 3,000 plus drug courts. That and AA and NA are the only two magic things that I ran into during my 6 years in public office. So, Carson, thanks for your leadership.
And I want to turn to Dr. McCants-Katz. So you do have this new position. So I'm going to ask you to explain exactly what it is. What does the Assistant Secretary of Mental Health and Substance Abuse do?
Well, so my job is to oversee SAMHSA's approach and its programs and how we are spending taxpayer dollars to address issues related to substance abuse, mainly the opioid crisis right now, and also to attend to the same sorts of issues on the mental health side with a major focus on serious mental illness. But the Assistant Secretary position was created to do more than just run SAMHSA. And so that position is one that is to outreach to other agencies within the federal government that also have a role in addressing issues related to behavioral health, be they on the mental health side or on the substance abuse side. So I spend a good bit of time on all of those kinds of issues.
On the substance abuse side, which is, what would you say your priorities are? And I don't know if they're filtered mainly through if those priorities are expressed mainly through SAMHSA activity or not, but please say a few words about that.
Sure. So, I've been a clinician since the late 80s, and have worked principally in addiction medicine since about 1991, and have watched kind of the evolution of the opioid crisis to where we're at today. It's very surprising to me. We knew back in 1991 that we had methadone and we had naltrexone then, and we were doing research. Sally and I were both at Yale then. We were doing research on buprenorphine, which became available in 2002. So we've known for a long time what works in terms of medication. We've known for a long time what kinds of psychotherapeutic interventions work, and we've also known for a long time that people don't get better just with medication. We have to have community recovery supports in place, and people who don't get access to all of those things have a hard time entering and maintaining their recovery from addiction. And so at this point, one of my major goals is to make sure that Americans do get access to evidence-based treatment, make sure that they get access to medications that work, to psychosocial interventions that work, that community supports come into play, and that medical, too often the medical side and the community support side don't talk to each other, and that has to change. And so that's going to be a lot of what I do. But the other piece of it that's very important is that we hear a lot from, you hear it from my agency, you hear it from Congress, about the need to invest more resources into addressing these issues. But we have to expand our workforce. If we don't expand our workforce and have clinicians that are available to provide that treatment, it doesn't matter how many dollars you put into it, people aren't going to get the care and resources that they need. And so workforce is another key issue for me.
I feel like I'm putting you on the spot here because I don't know that many good answers, but what about rural? What have you seen good models of what could happen in a very rural place, or?
So I think there are a few ways to address the issue of people that live in rural areas and don't have access the way we would hope that they would in more urban areas. One way to do that is through telehealth, and we're working on developing telehealth right now so that clinicians who are in an area where usually it's a more urban area, but through telehealth can do outreach and treat patients in distant places. Another thing we can do, and we're starting to look at this, is to provide incentives to clinicians to go to these rural areas. Provide loan repayment, for example. Let them be part of a program that already exists for certain healthcare professions, and perhaps expand it to others that would bring them into these more rural areas. That would, just doing those two things would up the ability to treat folks in more rural areas.
Yeah. And just before I turn to you, I mean, asking you all these questions, but could you? Everyone's heard methadone. They've heard buprenorphine. They've heard the four of them, right? Narcan, naloxone, buprenorphine, Suboxone, methadone, pretty much. And naltrexone, Vivitrol, basically. Can you describe the differences between them?
Sure.
I saw you try to do that on the hearing, and the guy cut you off at every minute.
Well, they only have a limited amount of time.
We have a little bit more time.
Yeah. So let me start with naloxone, because naloxone is it's an opiate antagonist. It's the overdose reversal agent, and it has high affinity for receptors in the brain that opioids bind to. So that if you take an overdose of an opioid and then you get naloxone, it will come into your brain, push that opioid off of the receptors, and you wake up. So the things that the opioids were doing, like making you sleepy, making you reduce your breathing or even stop breathing, those are reversed by giving naloxone. Naloxone is not a treatment for opiate addiction. The other three medications, injectable naltrexone, methadone, and buprenorphine, those are the three FDA-approved medications for the treatment of opioid use disorder. Injectable naltrexone is, again, an opioid antagonist, similar to naloxone, much longer acting. And so you can give a once every 4 weeks injection, and if somebody were to relapse to opioid use, it would block the effect of the opioid. And so, in effect, it gives people that opportunity to get back to their counselor, get back to supportive services to help them to get back on track with their recovery. Methadone and buprenorphine are both opioids. Methadone is a very potent opioid. It can be prescribed for the treatment of pain, generally in much lower doses than we order it for the treatment of opiate addiction. For opiate addiction, methadone can only be given in specially licensed and regulated methadone maintenance or programs, or what we call opioid treatment programs now. They are certified by SAMHSA. They're regulated by SAMHSA. They're also regulated, every state will regulate those programs. You cannot give methadone. As a physician, I could not give methadone to treat opiate addiction. I could for pain, not for opiate addiction. Buprenorphine is a less potent opioid. It's technically it's called an opioid partial agonist. It also has opioid effects, but is less potent than drugs like methadone. And so it's thought to be safe for an overdose. And because of that, that's why the government allowed it to be developed as a medication that could be available by prescription. So doctors who are specially qualified, and now nurse practitioners and physician assistants, specially qualified, can write prescriptions for buprenorphine to treat opiate addiction. That's a huge step forward, because the same doctor that provides your physical health care, or the same psychiatrist that provides your mental health care if you have a co-occurring mental disorder, can also write for your buprenorphine to treat your opiate addiction. By the way, they could also write for injectable naltrexone. That doesn't happen as much, but those two medications are available from doctors, methadone from an opiate treatment program.
Thanks. Thank you for that overview. And it does sound great, though one of the challenges is keeping people in those programs. And but turn to Carson Fox, because we hear all the time you can't arrest our way out of this, and I personally think we should say we can't incarcerate our way out of this. If people commit a crime, we can arrest our way out of it, and thank goodness we have wonderful diversion programs. Well, we should have more of them, but we have some wonderful ones, and at least we have others, that can take these folks from, they're not going to go to jail, but they're going to go to a treatment program, but there are going to be some expectations. And so that is what you oversee, the whole drug court philosophy. So please say a little bit more about how that's working, especially in the context of this epidemic.
Thank you. First, I want to thank AAI for having this. I think this is a fantastic event, and I'm humbled to be on a panel with these folks. This is an amazing opportunity for me. It's like I'm country come to town, y'all. I was a prosecutor in South Carolina. I think that people hear about drug courts a lot. Recently, the president mentioned them in one of his speeches before the Opioid Commission released a report. When the commission's report came out, drug courts were one of the 64 recommendations in the report. I think that there's a lot of misconceptions about drug court. How many of y'all in this room have heard of drug court? You've heard of it. Well, this morning I guess everybody has, because people have been talking. How many of y'all have been to one? Only a few. So to answer your question, what I'll do is I'll kind of describe to y'all what it is and how they came about. So a drug court it's a program. So it's not when people say drug court, oftentimes when I'm talking to folks out in communities, they'll think that there's actually a courthouse with drug court over it, and you go in there and that's the drug court. What it is actually a program that's a multidisciplinary process. You've got the judge involved, and you've got a prosecutor, you've got a defense attorney, you've got somebody involved in treatment, probation officer, oftentimes an administrator, who work together. And the way it works is, let's say all of you are in drug court, and you're in drug court, and we're the team, and let's say I'm the judge. You would appear back in front of me on a regular basis as the judge. And it would depend on what stage you were in the program. At the beginning, it could be as often as every week. And you're going to appear in front of me before we as the team see y'all every week. We're going to discuss how your cases are going. We're going to discuss how you're doing in treatment. Were you drug tested this week? How many times were you tested? Did you test negative? Did you test positive? And there are going to be responses as the judge that I give to you. So, for example, if you're doing really well, I'm going to congratulate you on this. And you might remember a little while ago, Sally was talking about the power of incentives, and she's written about the power of incentives. But she's also written about sanctions, and we know sanctions work too. Well, as a judge, I'll also be able to sanction you if you're not doing well. So, and those sanctions run the gamut. I can actually, I've seen drug courts where the sanction might be that I just give you a reprimand. I'm very disappointed in how you're doing. The sanction could be that you're asked to do community service. You could be asked to write a paper. You could even be sent to jail, but jail is a sanction that's used in a very limited basis. And as a matter of fact, in the research, the drug courts that depend on jail more actually have worse outcomes. So what do I see when I talk to folks that are misconceptions about drug court? Oftentimes when I'm talking to folks, they'll think, well, drug court is where my nephew who goes to Brown University is arrested smoking marijuana and he's in drug court. Nothing could be further from the truth. 90% of drug courts in this country are driven on felonies. People who are in drug courts pay restitution. Most people who are in drug courts have long records. As a matter of fact, what we know unequivocally from the research is drug courts work best for people who are in the research field. They're called high risk, high need. But what that means is that they are the folks who come into our system that if we do not respond to them, they will remain in the system, in and out of the system. They're the highest risk for reoffending. That means they're the folks, and as a prosecutor, I can tell you that when you're working with folks in drug court, these are the folks who are back in the system over and over again. They're the folks that local law enforcement know their names. They're the folks that people in the public defender's office know their names. The prosecutors know their names. I oftentimes hear statistics like 5% of the people use 90% of the drugs. Those are the folks in drug court. So these are people who are typically nonviolent, but they're in and out of our justice system all the time. So they come into drug court. So if y'all were in drug court, that would basically be your profile. And where drug court's trying to get you, and this goes to something that the chairman mentioned earlier this morning, we're going to do wraparound services. We recognize that when you come into the drug court, addiction's not your only issue. Okay, you're going to have a serious substance use disorder, but we're also going to have to address issues like where you're living, your family situation, your educational situation, your job situation, and we're going to have to help you improve upon all those things. We need to be prepared to give you a warm handoff to the community. Just quickly, some statistics on drug people. People hear about drug courts and how successful they are. I want to try to kind of bring that down to real terms. 60% of the people who come into drug courts graduate. And if you're familiar with the graduation rates in a typical treatment program, that's pretty darn good. It's twice the levels in probation, for example. When you've got people with serious substance use disorder who go into standard probation, that's twice their graduation rate.
Wait, say how long that is. Is that a year, 18 months?
It's actually a year to 18 months is a minimum. Some stay in even longer to that.
60% for that length is huge.
And it's because of the fact that the court has some leverage over all of y'all, if I'm the judge, to keep you in treatment that long. What we know is, and these are the experts on the science, and they've taught me this, is that the drugs that we see in drug court, when we're dealing with the opioid epidemic, and we're here talking about that this morning, 98% of drug courts are reporting that they have opioid use in their courts. I talk to drug court professionals literally every single day where people dying in their jurisdictions. Maybe not in their courts, but in their jurisdictions. So you've got these folks that are coming in, they've got serious substance use disorders, and, oh, I'm sorry, I was talking about statistics. So you've got 60% of the folks will complete. 75% of those folks who complete are not going to be rearrested. Now, if you live in my world, the criminal justice world, that is unheard of. That is an unheard of statistic. As comparison, the opposite's true. About 75% of people who are released from prison are guaranteed to be rearrested. So drug courts are tremendously successful. The issue I see with drug courts right now is that especially with the opioid epidemic, there are a lot of drug courts. There are maybe 3,200, between 31 and 3,200, but they're not serving enough folks. They need to be serving more folks. What we know is that an Urban Institute did a study on this a few years ago. They actually went into it was a study funded by the U.S. Department of Justice, and they went into the jails and prisons in the U.S., and at that point in time, there were about 2.3 million people in jails and prisons. That figure's about the same now. It's a little less. At that point in time, what they said was that of those 2.3 million people who were at that point in time in jails and prisons, 1.1 million would have been good candidates for drug courts had that been offered to them. And yet they were sent to prison. How does that happen? We've been trying to figure that out, and it appears that at least one of the factors is that oftentimes you'll have people on probation. And let's say that Sally and I have the same kind of charges and we're up in front of the court, and her attorney is more successful, let's say, at getting her standard probation, and I get drug court, even though we both have serious substance use disorders. So I'm going into drug court, and well, we know from the statistics, I'm twice as likely to succeed, right?
You got the bad lawyer, and you're twice as likely to succeed, and I got the good lawyer, and I'm twice as likely to relapse.
Right, and so she goes to probation, and you might ask, well, why does her attorney want her to have probation? Why do you think? Probation's great, and it's an integral part of drug court, but she might see a probation officer once every 30 days. Y'all are going to be in treatment, if you're again in a drug court, y'all are going to be in treatment three or four times a week, and you're in front of the judge every week, and you're drug tested at least twice a week. So her attorney wants her to get probation where she's drug tested once a month and she sees a probation officer once a month. But we have the same level of substance use disorder. Which one of us is not going to succeed? Her. So what happens when she fails probation in many places? Is she given the opportunity to go to drug court, or does she go to prison? And what we're finding is she goes to prison. And so one thing that we're currently pushing is trying to help courts understand that and kind of beat back against this perception that, well, Sally had her opportunity, she had probation, she shouldn't get something else. Well, why shouldn't she get drug court? Sally, when the judge sentenced her, the judge determined she's safe to be on the street. She's on a public safety risk, and she has a serious substance use disorder. Well, now that she's been unsuccessful there, can we try her in drug court? Essentially transferring her to a higher level of care, because we've seen such success in drug courts, which would obviously save tons and tons of money. If you're talking, if what Urban found is true, you're talking about that's half or over half of the prison population in the U.S., which is a substantial amount of money.
That's great. I have one more question for you, and I'm saving the big one for general. Just very, very quick. How has it been the integration of any of the medications that Dr. McCants-Katz mentioned, methadone, buprenorphine, Vivitrol, into drug courts? Because I'm obsessed with retention, and I would think that leverage combined with those medications could be amazing, but
I know that there's research going on.
That yet.
Some of the research is coming out right now, and so it's too early for me to really comment on it. I can say that I work for the National Association of Drug Court Professionals, and we educate courts on MAT across the country. And drug courts have really done an amazing job with uptake on MAT. And I don't know if these numbers are exactly right, but I heard recently at a national meeting someone from one of the federal agencies commenting that less than 10% of treatment agencies offer all three medications. The last time we did a survey of drug courts, almost 60% of drug courts offered MAT. So when you consider that they have very few resources to go to, they're really doing a great job going out there and identifying where it is. And drug courts have really recognized the need for MAT. The problems that drug courts have, for example, with accessing MAT, is the same problems we heard this morning. Some of them are in such rural areas that they just don't have access to it. There's literally, I mean, I've been to drug courts before that we hear about urban and suburban and rural. We forget sometimes that we have courts and folks out in the United States who live in areas that we call remote. They're not even rural, they're remote. I mean, I went in one county one time and I can't remember, they told me the county was like the size of Vermont and they had maybe 600 people living there. And so that's an issue that we've got is that the drug courts are more and more, we teach on best practices. We have a whole set of best practice standards. We have one standard specifically on substance use treatment, and that standard specifically says the court should be using the FDA-approved medications. And these courts are really trying to get there, but oftentimes they lack the same resources that any other community would lack.
So it's the same problem you were talking about. So General McCaffrey, after listening to all this, and I know you've traveled the country all the time and you consult a lot on this issue. If you were the drugs are now, what would you be doing?
A couple of data points to what Carson said. One's a large data point, the other one's sort of minor. The large one is 2.3 million people behind bars, 2.1 million men and women in the armed forces, active guard and reserve. So we've got this gigantic prison population. And if you go there, pick a study you believe, I'd say 60 to 80% of them have an alcohol and drug-related problem. And we release 500,000 a year, and by and large, there's no reentry courts and no handing over a known opioid addict to a MAT program, whatever. Another smaller data point, I was just a speaker at the Orange County Sheriff's annual luncheon, and the sheriff sitting next to me is a wonderful man. He says, last month we had a guy OD and be revived with naloxone 3 times in one day. And in each case, we discharge him from the hospital. The third time was lethal. And 2 hours later, we found his brother dead in another bedroom. So the scale of the problem is simply astonishing in selected parts of the country. Going forward, and by the way, interesting to me that you're now becoming the drug policy director, which is not a bad outcome. But the lack of focus in 3 administrations in a row on this issue has really been astonishing. I mean, it far outweighs many other problems we have in our society. And should there be a cabinet-level coordinator? Of course there should, for God's sakes. It can reach across various branches of government. The big actors in the thing, obviously, are Health and Human Services, NIDA, and AAACP, the Department of Education, Department of Justice, Veterans Administration. So who's pulling all this together in some coherent role? It's really shameful that there isn't some guiding light. I think the final thing we probably need to be concerned about, and it's sort of background noise. I never get involved anymore if I can avoid it in the marijuana issue. I'm on Jessica Halsey Lynch's Addiction Policy Forum, which is doing a lot of work on the opioid. But I stay away from the pot problem because I'm sort of a favorite invited dumb guy on the right to address it. But I think part of the problem has been an increasing tolerance of drugged behavior in our society. I tell people that in the background, Colorado and Washington and Oregon, we're watching fairly closely. Those forces, by the way, are clever enough to stop us from studying the issue, from collecting data on the impact of widespread marijuana abuse. But I do think that the country is sliding in the wrong direction. For 13 years, we had adolescent drug abuse coming down. For the last 8 years, it's going up. So look at your 8th graders. When you see increasing rates of exposure, early onset exposure to drug abuse, then stupid, in another 10 years, the hospital emergency room, the court system, the social workers are all going to see chronic addiction going up. So again, I'd say careful on just focusing on heroin use. If we had an excellent public health communication strategy, particularly aimed at heroin OD, most normal parents and coaches would say, let's get involved. We don't. Nobody's stepping forward and speaking on this issue except lone voices. And it takes courage and doctors to tell. One of your contributions has been the intellectual courage to speak your mind on issues. Because a lot of the politicians now fade in the background and say, look, I won the election by 52% of the vote. I'm not going against some number of people. My guess it's around 20% of the country that actually increasingly view all drugs in a libertarian or extremely left-wing manner as appropriate.
Yeah, I agree with you. It's certainly a different view, which is to say a much more heavy emphasis on public health than criminal justice. But in the course of that, some interesting developments that I think would never have been tolerated in the 70s when we were at the height of the last heroin epidemic, or if there were a cocaine equivalent for this, which is safe injection rooms. This is like radical harm reduction. I think one opened in Seattle already. Anywhere else? I know Boston is really okay. And these are areas, where people come and bring their drugs, and they inject them in the presence of nurses who have oxygen and Narcan who can revive them.
I think it's completely nuts.
Well, I'm
if you've got 14
studying
million
it,
people involved in addiction, if you're logically coherent, you don't go to a safe injection room with your own drugs, you get them at the hospital, the safe injection site. So, I mean, the easiest thing in the world is pass out clean needles, condoms, and a comic book about drug addiction. The hardest part is identifying people who are chronically addicted and getting them into science-based treatment.
Actually,
so I am categoric against. The magic is drug courts and Oxford House and AA.
I agree, but a lot of those folks have to come in through a criminal justice system or because they're motivated, and we have a population of people who aren't, and that's the justification, I'm just saying, for these kinds of more radical harm reduction. And ideally, at least they try, and I hope these are being studied by the local universities
Well, the Netherlands has studied it,
but they try to get people into,
you can get the whole package. We can give you, monthly support for your pet. We can move you into housing. We can supply the drugs. But if it's your son or daughter involved in chronic heroin addiction, you want them in treatment, not in these kind of programs.
Yes, me
But it
too.
costs money. It takes organizational ability.
Can I just say
Yeah,
one thing
sure,
about that, which is until we get to the point in the United States where everyone who needs and wants evidence-based, medication-assisted treatment with psychosocial services and recovery supports can get it, I don't think we should be talking about condemning them to safe injection rooms, which is what I see this as, because if you look at some of the literature out of Canada, out of Denmark, they've published on this. There's not high rates of getting people into treatment, and it's not equivalent to syringe exchange, which was developed to reduce the rate of deadly infectious diseases, HIV and hepatitis, and did that very well. But these safe injection rooms, that's a whole different way of looking at the issue, which is let's help people to continue this lifestyle. Basically, we as a society say, we give up on these people. We'll help them inject their drugs safely. And by the way, if they can't get into the safe injection site because it doesn't have limitless space, where do they inject? They inject on the streets around the area, which is not safe for anybody. So there are lots of issues with safe injection sites that have not been widely talked about, but there's literature out there, and so people should take a look at that.
Well, I'm curious. I'm very interested in how it will play out in the U.S. But yeah. Well, anyway, let's. It's 11:18, and I want to turn this over to folks in the audience. Yes, Gerard.
Here.
Gerard Robinson at AEI. I want to
About the package
thank my
of treatment.
colleague for putting together a very great discussion. What can we in the education community do on our side of the fence to address this issue? I agree with you, General. Kids are starting younger. Some of our kids, college, high school, dead or dying. A lot of our former students in the same place. What can we do, whether it's supporting drug courts or supporting at the federal or state level?
Well, we did an endless analysis on why kids don't use drugs. I've been to half the high schools and half the jails in America, and you walk into a high school and you get met by the football team captain and the class presidents and all that, and you say, who's using drugs in this high school? And the answer is everybody except us, which is categorically nonsense. We know that essentially, half the kids end up exposed to drugs by the time they're seniors in high school, and maybe 1 out of 4, 1 out of 5 are past month drug users. So we go to that group and say, how come you're not using drugs? And Columbia University did this great study, 73 risk and safety factors, and it all boils down to, did your mom and dad tell you don't use drugs? Did your homeroom teacher, did the coach? Was there an active communication strategy to engage young people with language and rhetoric and logic that makes sense for their age group and their background? And by the way, did they deliver the message in Spanish or Vietnamese or the appropriate cultural context? I think that's a big deal. We've asked educators to solve the failure of the American family, the failure of the funding system for public health. And you're doing a great job, but at the end of the day, it seems to me your impact on adolescents is so profound you can make a huge difference with a no drug use message. Brain on drugs, now we've got, MET scan evidence of drugs affecting the brain function. You can back that up with science. Anyway, glad you're engaged.
He's very engaged. He's doing great work. Yes, sir. Oh, you want to say?
Well, I could
Go
comment
ahead.
a little bit further
Yeah,
to say
apologize.
that for many years there was a program called DARE
Yes.
that was in the schools and wasn't shown to be effective, but has evolved into a program called Keeping It Real that has a very different very different way of delivering the message that takes into account some of what General McCaffrey was just saying in terms of communicating with adolescents on their own terms and messaging in a way that they can identify with, rather than lecturing to them. And that program has been shown to reduce use of gateway drugs, and so that is another that's another way to bring into the school's prevention activities. That program is generally given to 7th graders. It's been studied in 8th graders and is continuing to be studied, but we think it shows some promise.
Mm-hmm. John Soliday, economist. What do the addicts look like, those that are addicted to opioids? Are they in the workforce? Are they on the safety net? Are they living with an enabler? Do their parents go to church?
Yes.
A lot of them are healthcare professionals, anesthesiologists and ICU nurses, and that's one of the higher demographic groups. One of the lowest are younger Black Americans and members of the armed forces.
Workforce participation doesn't affect it?
Does, and if you were to look at data from the National Survey on Drug Use and Health, you would see that the majority, the great majority, by the way, about 80% of people who meet diagnostic criteria for illicit drug use disorders do not think they have a problem. And so they are, to some extent, probably not very well, functioning, and they are in the workplace, they are in the schools, they're in all walks of life, all levels of society. No one is unaffected.
Except stupid people. We found that really stupid people have lower rates of drug abuse than risk takers. You know, plastic surgeon female, 50 years old, chronically addicted to diverted legal narcotics.
Sir?
Hi, I'm Paul Malloy, and I usually push Oxford House all the time.
Oh my gosh, you must be floating on air.
But there are 2,380 Oxford houses now, about 19,000 beds at any given time. More than 400,000 people have gone through Oxford houses. Dr. Clark, who had been at CSAT for years, was at our last convention, and there were 1,300 Oxford House residents and alumni there, and they asked the audience to stand up how many had used heroin. 85% stood up, and most of them were going the route of drug-free, not going with methadone and buprenorphine, although we accept folks on methadone, buprenorphine, and Suboxone into Oxford House. Having given my plug on Oxford House, as an old person who watches television, all I see are these damn commercials for various drugs with warnings that to overdose may kill you and so on. But I'm reminded about the fact that we got cigarette advertising off the television, and cigarette smoking went down 75%. Now, I'm still a smoker, but for most people, getting it off television was a big thing. We as a society have to ask ourselves, why the hell are we advertising prescription drugs on television? It's because it helps the drug company to sell drugs, because the people watching it go into their doctor and say, I saw this ad on television, why can't I get this medicine? So politicians need to start thinking about the fact that we need, if we're going to change the culture, we have to stop all the advertising on television of various drugs. And, you know, some of those drugs may help me. God knows, my best friend these days at CVS calling me up saying, hey, your prescription's ready. But as a society, we've got to think about lowering the temperature with respect to the notion that a drug will fix every problem you've got.
Well, we didn't
I agree
just
with
get
that one.
we didn't just get cigarettes off TV. We stigmatized its use.
Yes.
And one of my colleagues once said, if you were on a plane about to take off and somebody was dividing lines of cocaine on his tray, what would you say? And what would you say if somebody lit up a cigarette? And universally, the entire plane would be outraged at the cigarette smoke and perhaps more tolerant of the drug use. So stigmatizing the use of illegal drugs. If you're a young girl, you're going to get pregnant, you'll look stupid. If you're a boy, you won't be able to play on the football team. Stigmatizing has a place in how cultures forbid some behavior and encourage others.
Well, the next time you watch 60 Minutes or any program on television, count up the drug addicts. And I would guess the television industry is now getting about 60% of its revenue from drug companies.
I must admit, I'm a little uneasy about what you say, though.
Yeah, so am I.
I think there have been court cases on this. It's a free speech
And it's
issue.
also, I think patients should know what's out there.
Absolutely.
And I think doctors should be informed, better
Yeah.
informed. And when it comes to opioids, now what we are changing, I think, is the way we rate them, for heaven's sakes, because one of the key evaluation elements was how well my pain was treated, and I think that's not I think we have to figure out a way to keep that too. But doctors felt they felt that if they didn't comply with the patient's request, which may have been clinically maybe unindicated, that they would suffer in some way.
I
Did you wanna
particularly
elaborate
like
on
the
that?
prostate ads during dinner, by the way.
I missed that. You asked questions, so I'm going to go to the gentleman behind you. And then
I'm Clay Fuller. I'm a Gene Kirkpatrick Fellow here at AEI, and I do defense and security studies, so it's not exactly my area, but a lot of you have touched on the idea of the role of the family. And so for a lot of drug addicts, they become drug addicts because of broken homes. And so what's the connection between the drug courts and the family courts and everything there? Because I think the family courts need some kind of reform.
Actually, it's a great question. We didn't even touch on this. One of the models, when you were listing that laundry list that we didn't get to, was there are family drug courts. And so what happens is, again, is that when there's a parent who is cited for abuse or neglect because of an addiction, a drug court steps in, which is a family drug court, and it's a family-centric model. And so it's very much like we talked about before. It's the same kind of a team, except it's a little bit different because it's not a criminal justice, it's a civil procedure. And they meet regularly, and you would come back in front of the judge. And the whole point of that team is to reunify that family, because what we know from statistics is that if I'm your child, my long-term outcomes are going to be so much better if I can stay with you. If we can get you into a good place and I can stay with you. And so that's the point of those programs. It's amazing to me that we haven't seen family drug courts take off more than they have. I mean, recently, probably everybody in this room has heard of veterans treatment courts, and veterans treatment courts have grown faster than drug courts grew. Family drug courts, for some reason, have stalled, and yet when you look at family drug courts and then you look at the regular family court system and you look at the rates of reunification, family drug courts have twice the rates of reunification. And it's, they really are, it's amazing. But then when you talk to folks that are involved in that space, when I talk to professionals in family drug courts, they'll talk about the underreporting of drug and alcohol connections in the cases that are filed to them. They'll guess that maybe it's 90% in some states, but since it's not what's written on the form, in some states it's like 16%. I mean, I'll hear these weird numbers where it might be here in some states and here in other states, and you'll ask folks and they'll be like, their guesses are, because this is from professionals working in the court system who see these cases, is over and over again you'll ask them, and their rates are no different than justice professionals when they use what the general mentioned, up to 80% of people in prisons have substance use disorder. They'll say about 80% of the cases. And then you'll look at the rates in the reporting forms, and that won't be from state to state necessarily captured that way. So it is a big problem. It's one of those things, too, that the family in a regular drug court, the regular drug courts, meaning adult drug court and veterans courts, et cetera, are also understanding and moving towards the family-centric model. Because these folks, and this is something that the chairman mentioned earlier in the day, they're going home to, if they're lucky, they're going home to a family, right? And if not, we have to place them in good housing. But to be sure there that you are capturing at least the idea that these folks have a family, and that when they go home, you want to be tied into what the issues could be there, and to also deal with those, or they're going to go back and they're going to be right back in the system again.
Thanks. That's a great note to end on, because it emphasizes how much this is not just a medical problem. Sure, we can give people buprenorphine, and we should if they want it, and it's often transformative. But a much bigger embrace of people who have these problems is needed. And, Congress is working on it, localities are working on it, states are working on it. It's tough because it's expensive, but it's key to this problem. You have to embrace the person, get them to stand still, and help them with all these other social issues that they have, what caused them to use drugs in the first place, and to try to help resolve the consequences of that drug use, the destroyed families and so on. So I want to thank you, three of you, for a wonderful discussion, great questions, and we're over.
I really love your last statement.